Greetings. My name is Elizabeth Byerly. It's my pleasure to introduce the next Journal of Pediatric Surgery top educational content talk. My friend and colleague, Rob Russell, will be discussing the new ATLS recommendations for pediatric resuscitation. As pediatric surgeons, we are most often the frontline caregivers for children with serious traumatic injuries or life-threatening hemorrhage. The use of the correct resuscitation fluids and blood components is paramount to achieving the best outcomes for these children. The APSA Professional Development Committee thought you should be aware of the recent changes and these newest guidelines. We welcome Dr. Russell's expertise in this arena and look forward to his talk. Rob, take it away.
I'm very honored by the invitation to give this tech talk for the 2021 virtual APSA meeting. But in the talk today, we'll discuss updated ATLS recommendations regarding pediatric trauma resuscitation and briefly discuss resuscitation strategies to include balanced resuscitation and introduce or reintroduce many of you to the concept of whole blood resuscitation. While I still have your attention, if you can remember one point from the talk today, here it is. Prior ATLS recommendations for pediatric trauma resuscitation had stressed starting resuscitation with a 20 cc per kilogram bolus of crystalloids, followed by another bolus for those patients not responding. This has now changed. Repeated administration of crystalloid boluses is no longer indicated, and a transition to O-negative or type-specific blood, if known, after one crystalloid bolus should be your new practice for those children requiring ongoing resuscitation. Again, if you remember one point today, stop repeated crystalloid boluses and transition to blood products early if you believe continued resuscitation will be required. Now to detail you on a bit of the supportive literature behind this and additional resuscitation strategies. Congratulations to Stephanie Politis and Dr. Rich Falcone and many other APSA members who are involved in publishing the findings of an important East multi-center prospective observational study this past year in regard to this specific topic. They put together 24 pediatric trauma centers looking at exactly this topic to determine the relationship between the timing and volume of crystalloid boluses before blood products and subsequent outcomes to include duration of mechanical ventilation, length of hospital stay, and mortality. They hypothesized that an earlier move to blood products and decreased crystalloid volumes would be associated with improved outcomes. They were correct in looking at over 700 patients with an overall in-hospital mortality just over 5%. In this study, almost 45% of patients received only one crystalloid bolus, 21% required transfusion of any blood products, and almost 10% required massive transfusion. To their point, over half of the patients who received a second crystalloid bolus required eventual transfusion. Patients who received blood after their first bolus obviously had a shorter time to transfusion and overall received less fluid volume during resuscitation. Each incremental fluid bolus after the first was associated with an increased odds of extended ventilation, ICU stay, and hospital days. Finally, not surprising, there was no difference in mortality since it was quite a rare event, and as most of you know, in our pediatric trauma population, and likely was underpowered to assess this outcome. In evaluating how we resuscitate pediatric trauma patients, I will briefly touch on two subjects that I believe are important and should be considered, especially in patients with suspected hemorrhagic shock. Although I bring these up, I understand that many may practice in resource-restricted settings, so we all have to do the best we can with the resources we have access to. First, the concept of balanced resuscitation, or trying to resuscitate with a relatively balanced transfusion ratio of packed red blood cells, fresh frozen plasma, and platelets for massively transfused patients. Essentially, we're trying to replace what has been lost through hemorrhage with component products. And be careful with the literature because there can be definition issues with high versus low ratios, depending on whether it means high use of fresh frozen plasma or high use of packed red blood cells. For time purposes, I want to highlight one published article that this audience may not be familiar with, published in Critical Care Medicine from Harborview Nationwide Children's and Shock Trauma. It details the largest population of civilian pediatric trauma patients, and its findings are quite similar to the findings of the Atomic group, which many of you may be familiar with, who also evaluated massive transfusion. This study utilized the Pediatric Trauma Quality Improvement Program data of over 120,000 patients from 2014 to 2016, of which they pulled out 583 patients who underwent massive transfusion, which was defined as greater than or equal to 40 mLs per kilo of total blood products in 24 hours. The overall mortality in those patients who were massively transfused was about 20%. And they split their group up into three groups in evaluating the ratios of fresh frozen plasma to packed red blood cells. First was the high ratio group, which was greater than or equal to 1 to 1. The medium ratio was greater than or equal to 1 to 2 or less than 1 to 1. So basically those patients who received slightly less fresh frozen plasma than red blood cells. And they compared both of those groups to the low ratio patients who received less than 1 to 2 of fresh frozen plasma to packed red blood cells. There was a 51% and a 40% lower risk of death at 24 hours for the high and the medium fresh frozen plasma to packed red blood cell ratios, respectively, when compared to the low ratio group. They also evaluated platelet to packed red blood cell ratios, which had no association with mortality. Now, the one difference in complication profiles to be aware of was a significantly higher risk of deep venous thrombosis and those with an overly robust plasma resuscitation, and those were greater than or equal to 2 to 1 of fresh frozen plasma to packed red blood cell ratio. So in resuscitation of patients that require massive transfusion, we should make an effort to keep the ratios of fresh frozen plasma and packed red blood cells transfused close to equal. Although the data on platelets is not as convincing, these should certainly be included in transfusion during a massive transfusion, but the pediatric literature seems to point to their ratios being less critical. Finally, I want to quickly comment on a renewed interest in the use of whole blood for trauma resuscitation in lieu of transfusion or component therapy. Certainly, this has become more prevalent at certain adult trauma centers and some pediatric trauma centers. Low titer type O cold stored whole blood offers several advantages over conventional component therapy. It's an efficient alternative, taking less time to transfuse. It has advantages in patients with limited IV access. It may reduce donor exposures, and it has a higher hematocrit, a greater platelet concentration and function, along with greater factor concentrations with less additive solutions. The group at University of Pittsburgh Medical Center evaluated their early yet small experience in a well-done study utilizing propensity score matching. They compared historical patients receiving component therapy versus recent patients receiving whole blood transfusion for resuscitation. The patients resuscitated with whole blood had a quicker resolution of shock, which was measured by returning to a normal base deficit. They had lower INR following transfusion with whole blood, and they were transfused decreased volume of blood products. Now, certainly this is a small study, and we will need to look for future larger experiences to further inform this practice. Among other challenges, in order to implement this, it certainly takes a very active and committed blood bank. In summary, I stress the new recommendations to consider blood product resuscitation in patients non-responsive to an initial crystalloid bolus with suspicion of hemorrhagic shock. Depending on your resources, those trauma patients that need significant resuscitation, we should consider transfusion of products in balanced ratios, at least equal FFP and PRBCs, or consider the use of whole blood if available. I appreciate the opportunity to address this important topic, and will be happy to field any questions, comments, and others' experiences in regard to this topic. Thank you very much.
Good afternoon, everybody. My name is Adam Vogel from Houston, Texas, and I have the pleasure and honor of joining the esteemed Dr. Russell in discussing some of these important topics. Rob, that was really an amazing talk and a great summary of the new ATLS recommendations, and really three really important papers looking at the perils of crystalloid resuscitation, the importance of a balanced hemostatic resuscitation, and really, really the amazing potential we have with use of whole blood and how we take care of these critically ill pediatric trauma patients. As we start in with questions, the first thing I wanted to ask you is, at your institution, or how would you recommend institutions work towards ensuring that their trauma resuscitations get that balanced resuscitative effort?
Sure. Thanks, Adam. I know it's been a passion of yours and mine to look at this, and I enjoyed your collaboration on several papers. But I think an important aspect in ensuring appropriate resuscitation ratios is first of all to have a massive transfusion protocol, and certainly that is an ACS requirement for level 1 trauma centers that are verified by the American College of Surgeons. For those that aren't, there's certainly some measures to take into consideration. Certainly working closely with your blood bank is very important to formulate this protocol, whether it be weight-based or whether it be age-based, and how you want to ensure those ratios. Certainly at our facility, it wasn't the process of putting the protocol together, but it was actually doing the protocol in a mock sort of setting and figuring out transport, figuring out the call to the blood bank, figuring out if you transition from the ER to the OR, from the OR to the PICU, or what, trying to get the blood products there efficiently, and then also stopping the MTP when it doesn't need to be still activated to try to prevent waste of products. And then certainly education around the PICU and NICU folks that may not know our literature, and making sure that they know what we put in the cooler should be transfused, and you shouldn't be hand selecting products, but trying to give the products that are in the cooler that mimic the ratios.
No, I think that's a great point. I think one of the challenges that we often find is, how we activate the massive transfusion protocol. There's clear literature in adults with nice, easy scores and systems that allow for MTP activation triggers, and we really haven't trickled that information down into the pediatric world. And I think that represents a huge opportunity for us as a pediatric surgery trauma research community to really develop the best ways of activating that, so we make sure that these kids get the ratios, really the ratios and the resuscitation that they deserve to improve their outcomes. Just out of curiosity, how do you guys how do you follow those patients, as they're receiving massive transfusion? What do you guys like to do?
Yeah, so I think initially when they come in, we get what we call conventional coagulation tests, which would be INR, PT, PTT, but certainly the use of TEG or ROTEM, which I see in the chat box, has become very useful, especially in adult trauma. I think many centers are using that, and we would follow our massive transfusion patients with a TEG as long as they're undergoing massive transfusion. I think that can be helpful as to what type of products that you might sort of then transition to goal-directed resuscitation, rather than just giving products to try to figure out, do they need plasma, do they need platelets? And certainly that can be challenging because there's some educational components related to TEG and ROTEM, and may not be used as much in the PICU and NICU community to sort of educate the providers about how to use that. But certainly that can be an adjunct to help guide resuscitation.
And I think that's a great point about the education and use of the different viscoelastic monitoring platforms like TEG and ROTEM. Our adult colleagues in trauma, use these diagnostic tests to manage patients all the time, because just the incidence of the severe trauma and the rates in which they're transfusing these patients is so much higher than us in pediatric trauma. There's a much more comfort level in the adult world, I think, than in the pediatric world. And that's something I know you and I have looked at in previous studies, as more and more centers use viscoelastic monitoring. One of the benefits that I think about when we think about viscoelastic monitoring, and we didn't really touch on it, in these three papers, but is the opportunity use of TXA. There's been a ton of work by Doctors Leeper and Dr. Gaines at Pittsburgh, looking at the different phenotypes that we see in these critically ill patient populations, especially with regards to fibrinolysis and these hyperfibrinolytic phenotypes and these fibrinolytic shutdown patients. And making that decision whether or not to give an antifibrinolytic like TXA, which is more commonly used in that setting, that kind of data can really be helpful to have real time to whether or not you think a patient would benefit from that, because we do know that those phenotypes can be associated with significant morbidity and mortality, and that you wouldn't necessarily want to give an antifibrinolytic agent to someone that's already in fibrinolysis shutdowns. And those viscoelastic monitoring tests really give you that information, and that's been shown in studies out of Pittsburgh and UT Houston and things along those lines. How do you guys incorporate TXA and viscoelastic monitoring in your protocols?
Yeah, so actually, my fellows have actually challenged me to look into putting TXA in our protocol. We don't have it currently in our protocol, and certainly I think there's Daniel Nishijima is sort of looking at this in the TikTok study, and that data will certainly be interesting to see. Certainly the military data, Pediatric, certainly shows a decrease in mortality. Certainly they're looking at a different population, more penetrating injuries, and sort of a different mechanism. But currently we don't have TXA in our protocol, but we have used it in kids that have ongoing hemorrhage. And curious as to, do y'all have it in your protocol, and how do you use it?
Yeah, so we do ROTEM as part of the initial resuscitation in the level 1 trauma labs, and then it's part of our master transfusion protocol algorithm as far as following serial viscoelastic monitoring with ROTEM over the course of the ongoing resuscitation, in addition to CBC and lactates and things along those lines. We have TXA as a consider. So, as a consider if they're not responding. There's certainly really good data in the adults with the CRASH 2 and the CRASH 3 studies showing that TXA in the first 3 hours can be of significant benefit. Less so data in the PED studies that you mentioned. A couple of questions. Dr. Arca asked how many people are using TEG routinely. There's limited data on that. There was a survey that was done, I think it was published in 2017 or 2018, that was something like 70–80%, I think, of folks were still using conventional coagulation tests, so PT-INR, PTT, and there was a very small minority that use TEG or ROTEM exclusively. I feel like it was like 4 or 5%, and there was like 20 or 25% that we're starting to incorporate into that practice. So it would be really interesting to see in a sort of just a general survey as to how that has changed over time.
Yeah,
it seems like there are several places that do incorporate TEG as part of their level 1 traumas, at least based on what I can see in the chat here.
Yeah, Adam, I'm going to pitch one question to you from Romeo Ignacio. One of the roadblocks I've encountered with our blood bank is the cost and need to transfusion. Our center has a relatively low volume of penetrating trauma. The concern is the loss of unused whole blood or any even blood products. How do you mitigate this at your center?
Yeah. And that's a fantastic point. And I think that is one of the most significant limitations and roadblocks in implementing whole blood. We do not yet at Texas Children's have whole blood implementation in our institution. There continues to be ongoing discussion as we get more and more data from the adult trauma world and also from the pediatric trauma world as to the benefits of it. I think the point is incredibly well taken. Thankfully, in pediatrics, the number of patients that we have to massively transfuse where whole blood may be a benefit is really low relative to other centers. And so at your center, if whole blood is not being used in other areas like the ICU, the cardiac ICU, in the ORs, it may be very challenging to prevent that wastage and make an advantageous cost-benefit ratio. Now, of course, if we get data that says it is far and away the best way of taking care of these patients, that may compensate for that. But we still have to learn more and more. And again, Dr. Gaines in Pittsburgh has really been at the forefront of translating these practices into kids and really generating the data that we use. So it's a great question, and it's a great opportunity, I'd say.
Yeah. Well, great. Appreciate all the chat, and I'm happy for any contact me, any further references or any other questions. Thanks, Adam.
Yeah, likewise. Happy to help. This has been great. Have a great rest of APSA.
Well, a great session and great talk by Dr. Russell and Dr. Vogel. They clearly know about trauma resuscitation. So very, very interesting, very lively discussion in chats, in the chat box. And, just a basic question about point of care testing with TEGs. I think Adam probably already commented enough because we both work at the same institution. But I would just throw that question also out to Dr. Rao and Dr. Novotny about the use of TEG at their respective institutions.
Yeah, to my knowledge, we have not used it in the ER, although we have recognized the need to change that. We had a really great grand rounds a few weeks ago by Dr. Barbara Gaines, and she also spoke about this to our whole Lurie Department of Surgery. I'm at Lurie Children's in Chicago, as you know. And yeah, I think it's a real priority for our hospital. What about you, Nathan?
Yeah, so we've not used it in pediatrics. I'm at Beaumont Children's, which is a hospital within a hospital, and Beaumont Hospital is this huge 1,100 bed hospital, and so the adult folks are using it in their critical care and management of adult ECMO, but we've not used it yet, particularly in trauma. Some of our issues come with just even ordering the test. You have to be a specific physician to order the test, and so I'm working on some COVID studies with TEG, but we haven't used it yet in trauma.
Yeah, I did see in the chat just a couple things to point out. There was a question about providing the links to the articles referenced by Dr. Russell in his talk, and just so everybody's paying attention that Dr. Powell posted those. So they have the PMID. You could click on that and save that in the chat. And also Dr. Arca pointed out that education with TEG has been highlighted by the PDC as a top education content area. So hopefully we may see that coming up as a even sort of more directed tech talk in the future.
So I'm curious, Texas Children's, are you guys interpreting the TEGs yourselves, or how did you guys do the ramp up for?
Yeah, I think for us, we actually have hematopathologists that help us interpret those TEGs. I think if you are Dr. Adam Vogel, you can interpret those TEGs yourself. But if you're Dr. Tim Lee, I need somebody else to help me interpret those TEGs. So, but we have, we're very fortunate to have like a dedicated hematopathologist or a coagulation team that will get involved anytime we are on ECMO, if we activate a massive transfusion protocol. So those are things that kind of fall within their wheelhouse.
Yeah, and the transplant community, it seems like they also, there's a role for it with transplant, like you said, with massive transfusion or really big liver cases and things like that. So you're right, like you can coalesce a team around that. Yeah. Absolutely.
What about you, Dr. Nathan? You guys have do you guys do that yourselves, or do people have, does other providers do that for you all?
Yeah, we're the ordering providers are the ones that are able to interpret the studies, and so basically we have a team of surgical critical care doctors that will order them and then manage the how to use the data. But as pediatric surgeons, we haven't gotten involved in it yet. And yet we had a grand rounds last week about TEG and are asking our adult colleagues to come in and talk to us as pediatric surgeons so that we can start implementation.
All right. Well, yeah, all good discussion points. So here we go. We're going to be moving on to our next tech talk. Our next tech talk is going to be given by Dr. Chris Weldon and Dr. Brent Weil. They're going to be talking about a very, very important thing within our pediatric surgery community, which is cancer care as a chronic disease. And I think it's something that was mentioned earlier that we may not often think about as much as we look at like 3-year survival and 5-year survival. But I think with the advent of just, better surgery, better medical care, these patients are living much longer than those terms, which is awesome. And I think Dr. Weldon and Dr. Weil are going to bring a great discussion and a great educational session for us coming up. So everyone stay tuned. Please go to the button down at the bottom of the page for next session to click to that and get ready for another great educational talk. See you guys in a bit.